My experience with drug resistance comes from two areas. The first is from taking care of patients with bacterial and viral infections. The second is from studying virus evolution in the laboratory. Although anti-infective agents are wonderful tools, when a bacterium or virus becomes resistant to an agent, they lose their value. We've seen a marked increase in the number of organisms that are resistant to all the antibiotics we use. The CDC slide lists 2.8 million infections with resistant organisms and more than 35,000 deaths just in the United States. I'm actually certain that these numbers are gross underestimates because of the way these things are calculated. So the problem in the US is in millions of resistant organisms and tens of thousands of deaths, and I can assure you that worldwide these are huge underestimates. Worldwide the problem is actually much greater than that. In the 21st century, we take it for granted that we can treat diseases like syphilis and gonorrhea with antibiotics. Interestingly enough, syphilis, because it replicates slowly, is actually still sensitive to the original miracle drug, penicillin. We still use penicillin to treat syphilis. Gonorrhea, on the other hand, became resistant to penicillin in the 1940s and has since become resistant to multiple antibiotics, including tetracyclines, fluoroquinolones, and now ceftriaxone, a third-generation cephalosporin, is our drug of last resort. The bad news is there are now strains that are resistant to ceftriaxone. Bacteria divide rapidly. They can divide every 20 minutes or so that in 5 hours you can go from 1 bacteria to 33,000. That allows for rapid selection of resistance without bacterial viruses or bacteriophages that make the process even easier by transferring resistance genes. Viruses do not replicate as fast, they take hours, but a virus can produce 10,000 copies of itself in a single cell in 6 hours, making it capable of generating progeny that are resistant to any drug. Over the last few years, we've been looking at viruses and their evolution and defining how viruses become resistant to antiviral agents. The influenza virus is an interesting example. Studies of influenza have indicated that the virus mutates more rapidly than other viruses, and this lets it escape antiviral agents. The flu virus is like the Red Queen from Alice in Wonderland. It's always mutating to avoid our antibodies. It needs to keep running just to stay in place. Several years ago, we began testing a drug called favipiravir to treat influenza in patients. In addition to treating patients in our research center, we looked in the laboratory to define the mechanism of action of the drug. Our research revealed that this drug works by introducing so many mutations that the copies that the virus makes are not capable of infecting cells. The virus experiences what is called mutational meltdown. The good thing about this drug is that it works in a way that should not generate resistant variants. We also found that this drug had activity against SARS-CoV-2, the agent of COVID-19. And in 2020, we used this drug to treat patients hospitalized with COVID-19. That study shows promise for the drug when given early. More recently, we've made the clinical observation that a drug that's used for Parkinson's disease and other neurological disorders may also prevent SARS-CoV-2 disease. The disadvantage of this drug, amantadine, is though it was originally developed to treat influenza, most of the influenza strains are now resistant to amantadine. The advantage of having an Institute for Drug Resistance is that when we hit this problem, we went to Dr. Celia Schaefer, who has experience in this area in working on drug resistance, and we're now working with her to develop analogs, that is, closely related drugs that may be more effective or may be less likely to generate resistant variants. If Dr. Schiffer and her chemists can find variants of this drug by looking at the structure of amantadine, we may be able to create a better drug. Alternatively, we may use both favipiravir and amantadine in combination in the treatment of SARS-CoV-2. Through both basic and clinical studies, we should be able to find a path to prevent and treat SARS-CoV-2 as well as influenza. but it takes focus in the laboratory on the problem of resistance as well as clinical trials. It's that combination that we need to eliminate drug resistance.